Welcome to Health Tech Matters, a podcast brought to you by the Pankhurst Institute at the University of Manchester. I'm your host, Videha Sharma. In the next episode, we are joined by Dr Sabine van der Veer and Dr Allison Crawford.
So I think digital technology has a promise to make it better. But the work that Allison and I are doing together is actually looking at, is it? And should we think about that more carefully?
We at the University of Toronto had developed a tool that helps to surface some of these digital health inequities. So it's called the Health Equity Impact Assessment Tool, or the HIA for short.
Hi Alison and Sabine, thank you so much for joining us today. I'm really excited to talk about a really important and topical subject around health inequities. Thank you so much for joining us.
It's really great to be here.
Yeah,
Lots of fun.
Thanks for inviting us.
Before we start talking about the topic and really get into some of the details around your work, I'd love to hear a little bit more about your background and your story. I know, Alison, you're a psychiatrist by background, and Sabine, you're a health informatician, but you've both ended up working in the space around health inequities. I'd love to hear a little bit more about how you ended up crossing paths and how you ended up working in this space and collaborating. Perhaps if we start with you, Alison.
Yeah, so it's been very fortuitous. I didn't really envision the path this was going to take, but yes, I'm a psychiatrist and a health researcher from Toronto, Canada. And the main part of my job was organizing psychiatry outreach to rural and underserved areas in Canada, so the north of Ontario and Nunavut. And what we know is, so Canada has a public health system, but healthcare is not easily accessible in some of those places. So I've really been concerned with health service delivery, and then got excited probably about 10 years ago in the opportunities with technology to extend that access, and that got me involved in the digital health space. And as a researcher, lots of questions came up.
Yeah, my path is slightly different, like you said. So I'm a health informatician by background. So I was trained in Amsterdam, came to Manchester almost 9 years ago now. And when I started my work here, lots of the projects I was doing were around technology to enable people to collect data about their health using their smartphone or using their Fitbit or using the web, and then sharing that with their doctor. And as I was doing more and more projects, the thing I noticed is that, there's often the well-off people that were actually picking up the innovations that I brought to them. So it's the people who were more highly educated, who had a good support network around them and could learn new things because they had a carer or a partner. They had a newer version smartphone available. They already had a smartwatch or a Fitbit. So actually what I was seeing is that the people who were already doing quite well in managing their life and their health were benefiting from what I was, trying to bring in terms of improvement, whereas the people who were, actually in most needs because they didn't have this support and they might not have, the smartphone that you needed, they couldn't really improve their outcomes through the innovations I came up with. And it really sparked an interest for me to sort of try to not make it worse. So by doing that, you're sort of worsening health inequalities that are already existing by introducing digital tech. So for me, that really, that's the motivation for me to get into this space and try to not make it worse, but maybe even make it better.
Fantastic. Now, I really, really enjoyed, Alison, what you said around access to healthcare and the inequities around that. I'd love to pick up for those who perhaps haven't worked in health inequity before or haven't got a full understanding of it, because from my perspective as a healthcare professional, when an individual is sick, they need access to healthcare. But the reason they are sick in the first place may not be because they didn't have access to healthcare in the first place. It could be because of other determinants of health. So do you think it would be great to first of all hear maybe a definition around what health inequities is, and then perhaps we could expand around the role of digital health? And I know, Sabine, you've already touched on that, so that'd be great as a starting point.
Well, one word that keeps popping up that I think helps is equality, and contrasting that with inequity. And I like to think about, so in Canada, we have this wonderful health system where everyone gets an equal amount, everyone has equal access. But the fact that not everyone does as well in terms of health, I think, almost defines health inequities. So to me, it is, unequal outcomes or inequitable outcomes to healthcare, despite sometimes having the same resources, and it is because of these social things that you mentioned. So we know health is it's biological, but it's often an expression of the social through the biological, and they're intertwined. So things like education, poverty, or social or economic resources, early life experience, housing, food, all of those things contribute to our health. So if those things are already inequitably distributed, then health becomes inequitable. And I think that's a nice bridge to thinking about when you layer the digital on top of that and you expect it to solve those social problems. Sometimes we call it the digital divide, and that digital overlay can actually worsen or widen those inequities.
Yeah, I think it's a good way to think about it. So you have inequalities and inequities in people's social and economic circumstances, and that often impacts on their ability to use digital tech or their access to digital tech. So once you introduce that to access healthcare services or improve them, you actually make that divide bigger. So I think that digital tech can make it worse, and sometimes you try to use it to make it better, so to give people more access, but then because you haven't thought about it properly, and you forget that people might not have the technology to use it or the skills to use it, or they don't trust it. So I think digital technology has a promise to make it better. But the work that Allison and I are doing together is actually looking at, is it? And should we think about that more carefully?
Yeah, fantastic. So I think what I'm hearing there is that there is a need to better design or understand the needs of individual groups or populations so that we can design the technology in a way that's actually going to reduce health inequities rather than widen that gap. So it'd be great to hear about what your week was like in Manchester, Allison, and what have you guys been working on? Did you enjoy the weather? Was it as expected?
It's been wonderful. Manchester is a really vibrant place, and the university is beautiful, so welcoming, and so I can't say enough good things about actually being here. And I think being the Pankhurst Institute is a really exciting place. The fact that it is making space for these kinds of questions, this kind of research, and bringing people together from very different research perspectives, different methodological perspectives is very exciting. So I met Sabine through a collaboration between the University of Toronto and the University of Manchester, and you can hear the synergy in the things that we're interested in and do. And we at the University of Toronto had developed a tool that helps to surface some of these digital health inequities. And we're collaborating on making the tool better and also applying it to different digital health technologies. So it's called the Health Equity Impact Assessment Tool, or the HIA for short.
So from my perspective, we had a lovely week. It's been hard work.
It was busy.
But we had lots of fun. And before Allison came here, we already did some work online. So we used Zoom to apply the HIA tool that they developed on a technology that we developed here in Manchester. What I learned from that and what sort of was reinforced by the visit and the things that we did this week is when you work in digital health and probably in healthcare in general, you are aware that equity is high up on the agenda. It's really important, and everybody tells you, think about it, do something about it. But not really a lot of suggestions and tools around that actually help you do that. So I was really excited to meet Allison, and she actually has a proposal or an approach to doing that. And I think what I've learned is it's hard, but also so we do a lot of work with stakeholders. So we might get onto that in a minute. So the tool is not just a checklist that you go through. You could, but it's actually helping you to have a conversation with the people that use your tool or that you want to benefit from it. So it's almost a stakeholder engagement tool. Would you agree with that, Allison?
I think that's a very important part of it, is you need to engage with the users, because it's very humbling. I mean, I come from a very privileged place socially, educated professional. Which is the problem with the checklist approach to health inequities, because you can read, oh yes, give everyone a smartphone. I mean, that is not the solution to health inequities. So you need to hear from people what their real lived experience of using technology is and what their hopes are, what their values are around how they want to receive healthcare and what it's like to interface with technology and trying to meet their own goals. So I think you're right.
Great. So picking up on that, I'd love to hear perhaps an example of where you've used the tool, and indeed perhaps hear some of the things that your stakeholders have told you about how they'd like to involve technology as part of their healthcare experience.
Yeah, so there are a couple of examples, but maybe I'll pick one that came up yesterday because it's so recent, and we had a conversation with people with rheumatoid arthritis. So we had people in the room that had lived experience, so were diagnosed with rheumatoid arthritis, and we had some doctors in the room as well. And we talked about if we give you a smartphone app to monitor your symptoms, and we send that information to your care team, so to the rheumatology team, what are the barriers, do you think, for people like you to use the tool appropriately? And could you help us think through what equity issues could arise? And we had a woman from Black African heritage. So she had rheumatoid arthritis for a couple of years already. And as part of what we are offering in this digital intervention is that we help people to assess their own tender and swollen joints. And then they can record that in the app. And there's a little mannequin, so a little body shape where they can indicate which joints are hurting. And she said, actually, if you have black skin, looking at which joints are affected is actually quite different from when you have white skin or when you're overweight. This video that you provide to help us with that doesn't really help. And I'm, where I'm from, I never knew what tender even meant. So there was language, there was skin color, or having a diverse patient group in mind that, would really improve access for people like her to use this tool in the way that we intended it. And it was really an eye-opener for me, because we thought we did a great job. We work with patients, make this video, and then she said, well, my community is not going to pick this up because it's a white middle-aged lady that has, perfect weight. Yeah, people in my community are not, are not so much not interested. They think it's not for them.
So do you think there's a role for introducing things like the tool earlier on during the ideation phase of digital health interventions? Do you think this needs to be pretty much at the start or part of the first process?
I think to look at health inequity should ideally be baked in right from the beginning, but it's also iterative, because sometimes when you're envisioning something, you have this very idealized version of what it's going to be, and you need to check in at different points. So, early in the conceptualization, in the testing, but then also once you've implemented something, to go back and see, does it have the impact that you intended? Who is using this tool? Who's not getting access to it? Who only uses it once or twice? And sometimes barriers come up that you didn't anticipate. So at any point, and hopefully revisiting.
Hi, my name is Claudia Lindner. This podcast is brought to you by the Christabel Pankhurst Institute at the University of Manchester. At the Pankhurst, I'm the lead for the translation theme, and that theme is all focused around how can we facilitate and encourage the translation of developments from within the university to clinical practice.
One of the challenges that people might raise is in an increasingly challenging environment, particularly from a kind of financial perspective and challenges around research budgets. People might say, well, is this an important part of the research life cycle? And if we had to make choices, is this something that we can scrap or maybe add on later on? What would you say to that kind of an approach or an argument?
Let me grab the mic. I don't know what your experience is in the UK, but even from a selfish point of view of researchers and tech developers, we know that so few people actually end up using these products and interventions. So if you want people to use it, if you want them to benefit from it, I think it's absolutely critical that it works for people. And, we're all here to improve people's lives and outcomes. So yes, I think it should be top priority.
Sabine?
Yeah, it's you're asking the question, so we will definitely say you can't scrap it. But the reason why I think it can't be scrapped is if you look at how health interventions and digital health interventions as part of that are being evaluated and assessed to see whether they need to end up in the guidelines, for example. It's really looking at, does this new tool or this new intervention actually improve things at a population level? So if you look at everybody in a certain target population, on average, does it improve things? And if it does, NICE, so the national guideline body in the UK, say, well, yes, let's put it in the guideline then. But at the same time, because there are subgroups that might, not benefit from it, or it gets even worse for them, but because they're a minority, they don't affect the average necessarily. So the decision to sort of introduce something doesn't take into account the fact that there are groups left behind. So in my opinion, I think we should work towards a model where we not just look at improvement at population level, but also have a measure for whether it widens the gap between subgroups. So that might be a measure of equity. And I'm not saying that equity should always be more important than the other thing, but especially in situations where we know the gap is huge, I think we might prioritize equity as a thing that we find more important than improving the overall average.
That's really good to hear. And it reminds me of a common example that we learn in medical school around childhood asthma, where the overall population rate of childhood asthma has been declining. However, the rate amongst children who live in socially deprived areas where there's perhaps more pollution, not enough access to exercise or outdoor time, the rates of childhood asthma are rising, and indeed associated hospital admissions are rising. So there's something really that needs to be baked into our design of health interventions, digital or not, that's really going to change that. So picking up another challenge around digital health and inequities, and I think you mentioned at the start, Alison, the role of data. Do you think there is an increasing awareness of the importance of capturing data within healthcare settings, but also outside of direct healthcare, that's going to impact the way we make decisions around policy, strategy, and where we should be prioritizing?
Yes, in a short answer. I think there are multiple considerations within that. Privacy, who collects this data, how is it used, do you have control as an individual over whether this data is being collected? And I think that's an equally important debate. In Canada, and I don't know what it's like here, but there's also a lot of debate about race-based data. So we know not all health inequities are linked to race, but some are, often when they intersect with other inequities like poverty and social deprivation. But there are different schools of thoughts about collecting race-based data. Some groups, like I work a lot with Indigenous groups, put a lot of rightful emphasis on having ownership and sovereignty over their own data. So I think we have to be very careful when we collect it. And we need to look for leadership from within communities. So we need to look for people to enter healthcare, to enter research, so that they're working with their own communities. And it's not just people from outside or from the academy going into communities and reinforcing these ideas of deprivation and disadvantage. And so it has to come from a place of strength and to come from within communities. So data is important, but who collects it, how it's stored, how it's used is also important.
So that's similar to, I think, picking up what you said earlier about we're in a very privileged position, aren't we? Coming from our backgrounds. So how do we involve those that are actually subject to the disadvantage, and how do we get them to be, I guess, co-designers or co-producers of part of the solution? Any ideas how we can do that, Sabine?
Well, it's sort of, I agree with what Alison said. It's probably there's no one size fits all, and there's no magic bullet to do that for everybody. But I guess there are definitely certain groups where we're not the right people to engage directly. So you're looking for leaders within community. So we're doing some work, it's under development, but we're doing some work with Muslim communities in Greater Manchester, where actually the imam is probably the person to speak to. And we need to work with them so that they can then talk to the community. And after they've done that, they're probably ready to talk to us. But it's so we've tried to engage without this person in the middle to, go to community centres, for example. And then what they tell you is, you need to come a week after week after week to our, Sunday afternoon lunch and build relationships. If you want to ask the question, do you want to take part in my study? So we could do that, but it's probably better to look for people within communities to, build a message and think about value as well, because it's hard if you're not part of a community to think about what the values are, what could be the value of the thing you're trying to do for that particular community. So that's definitely one option that we're looking into.
I really like the word relationship, though, too, because too often we get into these rarefied spaces where it's the technology, and it is very exciting, new technologies, but it is ultimately about our social lives and how these technologies are integrated, how they help bring us together or keep us apart. And I think relationship and the social context of technology is so critical.
Great. So you've done all the hard work, you've managed to build relationship with a group that you're hoping to impact, and you've designed a solution together with them that has been validated and hopefully is going to make a big impact. One of the challenges that we have in the academic world, there is still a barrier to translating that intervention from an academic space, from a research project, into a real world application. Do you guys have any suggestions or ideas on how we can have that translational pathway run more seamlessly and therefore impact society better with our academic work?
So what we had a discussion yesterday with somebody from the Pankhurst Institute who's looking at developing, I think she called it a toolkit or a roadmap, where you have the translational pathway with, the early stage conception level innovations, and then all through evaluation and implementation to adoption. And we talked about how could the hire as a tool fit into those different stages, and what would be the right time to prompt researchers or tech developers to think about equity. It's a really interesting conversation, and I think we ended up saying, well, definitely at the beginning, but we probably need to do a little bit more work around thinking what aspects of the hire as a process, and what types of outputs might you expect depending on where you are in that pathway. And the plan is when Allison goes back to Canada, we keep working together, and the plans that we have are really trying to do more hires, but with technologies at different stages, and then use those experiences to learn what the hire brings, depending on where you are. And hopefully we can then work with the Pankhurst, for example, to help researchers pick the right aspect of the hire or think about it in the right way at the right stage.
Yeah, I think that's the aspiration, and I think it's realistic as well, because we'd love people to, do a full and complete hire at every stage, but it's intensive, it's resource intensive. It really means engaging with people. So I think the more that we can do to streamline it and integrate it with other processes, so whether it's, translation, implementation, whatever phase, the more we can streamline it, the more likely it is to be picked up.
Great, brilliant. Well, thank you so much for sharing all those insights. I'm really, really excited to see what comes from your research going forward. If people want to learn more about the Hire tool itself or any of your other research, or maybe even get involved, do you have any suggestions or resources that people could look at?
Well, we will definitely report on our collaboration and on the projects that we're doing on the Pankhurst website. So there's a digital health inequity section on the Pankhurst website. So there will be a case study of the work that we've already done, but we'll probably also make sure that the hire is available there. So we've just got paper copies, like fresh from the press this week. So, but the digital version will be available, and we'll make sure it's in that section for people to have a look at. Well, and just watch this space, because we'll be working, doing more work around this over the next coming months, and we'll make sure that, whatever we find and develop will end up there.
Fantastic. So it sounds like this is still an emerging space, and it feels quite cutting edge to me in many ways. And I feel like there's tremendous potential for this to really impact the way we design digital health interventions and hopefully reach those previously disadvantaged populations in a more meaningful way. Would that be fair to say?
That's definitely the aspiration. Mm-hmm.
Yeah, 100% agree.
Brilliant. Well, thank you so much for joining us today. That was really, really fantastic. And yes, thank you.
Yeah, thank you.
Thank you.
It's been great.
In the next episode, we talk about wearable sensors for monitoring the human body in everyday life. We're joined by Dr. Alex Cassin, who'll give us a glimpse into the future of digital technologies in the NHS. Hope you can join us.